Tēnā koutou katoa. Good day, everybody, and thank you so much for the invitation to speak today. It's really a pleasure and a privilege to be part of your discussions as you think about how to centre equity within palliative care. What I want to do is to share a few of my thoughts about how I've addressed or tried to address equity within my work, particularly within my research. And I hope one day when the world opens up a bit, I'll be able to come and visit you in your beautiful country and learn your experiences about promoting equity within palliative care. Because I really believe that we're right at the beginning of truly understanding what it means to centre equity within palliative care practice, policy and research. And we've got a lot to learn from each other. So where to start? Well, I'm actually going to start with myself, and that is certainly not because I like talking about myself. One of the reasons I became an academic was because I thought I get to spend a lot of time in libraries rather than doing things like this. But in all seriousness, I think we need to start with privilege rather than with what we usually start with, which is the marginalized, the disadvantaged, the oppressed. And this sort of language renders the other half of that equation invisible, and it actually sort of closes off thinking about the problem and also about the solution. So we could start by thinking about why you invited me to speak to you today. What made you think I had something that was worth listening to? Well, it probably helps that I'm a professor. And what has helped me become a professor? Well, if you look at the socio-demographic characteristics of professors in Aotearoa, New Zealand, where I'm working, then you'll see that 85% of professors are white, which is not reflective of the demography of the population. In particular, only 3.5% of professors are Māori, the indigenous people of New Zealand. And that's despite the fact that Māori make up almost a fifth of the population and also have rights supposedly enshrined in law with the Treaty of Waitangi, which means they should be involved in governance of public institutions such as universities. Being a woman didn't help me. So still in New Zealand, only about 1/3 of professors are women. And this is reflective of statistics across the world. It's changing a bit, but still women are less likely to be promoted. And there are many, many reasons for this, but again, something to really bear in mind. It probably helped that I was born into a country where girls could be educated though, and that my parents had the resources to support my educational aspirations. So all in all, these intersections of privilege that I've experienced have left me in the position, the fortunate position of having a platform to share my views. And I think it's really important for us to make that sort of privilege visible and to think really critically about the voices that we don't hear. So I've always had an interest in equity. That's really what brought me into palliative care in the first place. I began my sort of journey in palliative care when I volunteered in a hospice for people with HIV and AIDS in London, and that was in the late 80s and early 90s. And as you can imagine, sort of equity, stigma were huge issues for that population of people. And that experience taught me a lot, and I carried that with me through my work. I think the other huge learning for me has been in moving to Aotearoa, New Zealand. That was over 12 years ago now. And in doing that, it opened up a whole new experience of equity. And it led to me founding the Ārai Palliative Care and End of Life Research Group with a range of colleagues from different disciplines. There's about 15 to 20 of us and postgraduate students as well. And what's been really critical to the development of Ārai is our way of working, which is supported by kaumātua or Māori elders, and works along a bicultural framework which centres Māori knowledge and ways of doing things. And we centre this even when we're working with non-Māori populations. And if you want to read a bit more about the development of Te Ārai, we've published a paper, and there's a link here. And also all the references that I mention are listed at the end of this presentation, and I'm sure will be made available to you if you're interested. I think it's important to say that I'm speaking on behalf of a lot of different people. I'm involved in a range of projects, both in Aotearoa and in the UK, looking at aspects of equity. And really, I'm gleaning from those projects some lessons. And these are my lessons, I have to say. And I won't blame anyone else for them if there's disagreement as to the direction. This is really my personal reflection, because that's what I wanted to share today. But there are a range of projects and data that I'm drawing from. And again, you can find more details about these projects on your website, on our website, or you can always get in touch with me. So what I want to cover today is three things, really. Firstly, to talk about why and how palliative care is inequitable. And I want to do that quite briefly, because I think that's now a given, really. There's been a lot more discussion around equity and palliative care, which is great to see. The second thing I want to think about is where we go from that point of understanding that inequities exist. And I'm going to caution reflection prior to action. And then finally, I really want to argue that we need a paradigm shift in palliative care, whereby we centre equity in everything we do. And it's not just the responsibility in research, for example, of people who are doing research in the equity space, or, you know, the equity development officer. It's all our responsibility. So I'm sure you've seen a diagram like this before, and I'm sure you've thought about the differences between equality and equity previously, but I just wanted to situate this within a palliative care space. So I think in this first diagram, it's assumed that everyone will benefit from the same supports. People are being treated equally. And I guess this could equate to a hospice setting up within a community and kind of expecting that everybody has equal access to the hospice without understanding some of the barriers that might exist for certain groups of people. In the second image, people are given different supports to access the hospice, if we're going to continue with that analogy. So it might be that materials about the hospice are translated into different languages, the efforts are made with, for example, the menu to make sure it's more inclusive, and it doesn't just reflect, certainly within the Aotearoa context, a Western dominant standpoint. However, if we really want to move to equity, then we need to start thinking about the systematic barriers to participation. And I guess within the context of a hospice, this would actually be going to the community and saying, what is it that you want? And starting from that point, rather than starting from an already existing hospice building. And I know this is hugely complicated within the context of development, so I'm not necessarily advocating that this has to be the way forward, but I think that's, you know, it's a good metaphor for the way we approach equity in lots of different areas, that there is a set idea about what will happen, and the power that the people we are trying to support participation by is actually not significant enough to achieve change. I've been involved in a number of critical reviews of the palliative care literature recently, trying to sort of situate equity and provide a way in for people to understand some of the critical issues. So the first one I led was around gender, and that really exposed the gender inequities within palliative care, as well as explaining what we mean by gender and the language around that. And I've also recently led one looking at palliative care and poverty and deprivation. And we've done a lot of work as well within Te Ārai from a Māori point of view, looking at how palliative care services, how end of life is experienced by Māori. And the conclusion from that significant body of work now is that the imagined palliative care patient around which practice and policy continues to be formulated is insecure housing, is white, middle class, and male. And a good example of that was that I Googled palliative care patient into the Google search engine, and this is the first image that came up, and most of the other images were very similar. And really that translates into inequities in palliative care in relation to who gets to access services, policy assumptions and our philosophies of care. And then finally, that translates into service user experience. And I just want to talk about this very briefly, but as I said, there's things I've written that you can read, and other people have started writing in this space as well. So in terms of service access, I just wanted to give you an example that maybe isn't as talked about as some of the other examples out there, and that relates to people with serious and persistent mental illness. So Helen Butler, who's a member of Ārai and who's doing her PhD with me at the moment, found in her master's research that people in New Zealand with serious and persistent mental illness were 3.5 times less likely to receive specialist palliative care than the remainder of the population. And her PhD work is really expanding that to look at, well, what services are people getting, and actually what are the priorities for service users with serious and persistent mental illness when they think about palliative and end-of-life care. In terms of policy assumptions and philosophy of care, I think some of the key tenets of palliative care are often reflected somewhat uncritically within policy documents, and certainly seen that here and in the UK as well. And particularly concepts such as home and choice. And this quote here is from the Scottish photographer Margaret Mitchell, who we're working with on a project led by Dr. Naomi Richards, funded by the ESRC, looking at the experiences of home dying for people living in deprivation. And we're working with Margaret, who's taking some photographs in collaboration with people with palliative care needs, and they are also taking their own images. And she writes, "I want the viewer to ask themselves a question about how society operates, how choice is related to opportunity and environment, to see that sometimes people choose what they do because really not much has been offered in the first place." And we also have done a bit of work looking at choice from a gender perspective, particularly in relation to advanced care planning, concluding that women feel they have very different choices to make at the end of life than men, and this was older women, so there's probably a bit of a cohort effect going on here. But you know, for them, they felt they had fewer choices essentially, because as one of them said, it's the wife who has to look after the man. And so it's unsurprising that these factors translate into differential end-of-life experience for people who experience inequities, who experience structural marginalization. It translates into health professionals' attitudes and behaviours, and certainly in all the work that I reviewed for our gender paper and our poverty and deprivation paper, there's a lot of information that comes out about racism, about heteronormativity, you know, about the sort of stigmas and prejudices that we all carry. You know, health professionals are no different from the general population. We all carry these biases, and I think that's something that's really important to acknowledge, and that's certainly something that is addressed through, for example, anti-racism work. And this can translate into people even being denied pain medication. So we found evidence that women were less likely than men to have serious pain acknowledged and appropriately treated. And similarly, studies in the US, for example, show that Black Americans are less likely than white Americans to have their pain appropriately managed, more likely to be labelled drug seekers. And we've certainly seen some of that coming out in our interviews with Māori at end of life as well in New Zealand. And we've recently finished a project, and I'll show you a resource from that project a bit later in a minute. But one of the things that we found in this study investigating Māori end-of-life care cultural customs was that often whānau, which is families, are expressly forbidden from carrying out their end-of-life cultural care customs, and that they have to do these under the radar. And, you know, that was really interesting to explore, but also really worrying in terms of the way that impacts upon people's willingness to even engage with health services in the first place. So if you're anything like me, and you probably are, as you're interested in palliative care, then all this talk of inequity and understanding that these inequities exist kind of fires you up to actually want to do something about it. And I've certainly had that experience, but one thing I would really recommend from my experience is the need to reflect before acting, because I think there's some really key principles to think about, particularly when you're not from the community or communities that you're trying to support. And I want to talk a little bit more about the study that I just mentioned, and in particular I want to share with you a digital story which was undertaken by one of our whānau or family participants. So as I said, this study, which resulted in the Te Ipu Aranui website, explored Māori end-of-life cultural care customs, and it was called for by our kaumātua, the Māori elders that we work with, because they were really concerned that because of colonisation, these cultural care customs were being lost. And certainly they were actually banned. Some customs were banned when sort of the colonial state became established, and have only relatively recently, the acts that forbade those happening have been repealed. So that was the context for this study, and we ended up doing lots of interviews with whānau, with health professionals, tōhanga or Māori spiritual leaders, and this was a project led out by my Māori colleague, Dr. Tess Moiki Maxwell. And it resulted in this amazing website, and I'd really urge you to have a look at this website. So this website was developed by Māori for Māori, and I want to play you one of the digital stories from two bereaved sisters who talked about looking after their dad at the end of life. And when I play this, I just want you to think about, you know, what message are they trying to tell us about that experience?
Oncology doctor said to my father, "You will only be alive for 2 months." He needed to be home, surrounded by his family in his last days of care. I asked Dad, would you like to come home? And he replied to me, "Coming home to what? There's nobody here." And it was true. The house was a shell, there was no toilet, we had no water access, and we had no power. We had a lot of work to do. I say we had to bring colour back into the house. We had to bring love, laughter, love, and more family. I was reaching out to the family that I hadn't reached out to in years, and they were coming, and they were coming so hard. It was amazing, overwhelmingly awesome.
So that gravitational pull, that pull towards home, took us back to Dad, took me back to Dad, and Dad took us back to our papakainga, back to Te Tii.
So that was us. We made our journey from Auckland to Te Tii, Monganui, Ngāti Rehia.
And going back to the papakainga, just connected. It was that connection with everyone else's vital life forces which came in, and it was a puna, a well that we could start accessing.
Can we use your shower, your amenities? Yes, was the doors were opening to us, which made this job of looking after our father so much more easy.
Everyone knew, we all knew what our role was. We just jumped into the role and we just did what we needed to do to complete the jobs, our roles, but to uplift and to whakamana Dad. And I believe that being back home, that was the whole purpose of being back home, was that to uplift him.
The love between two daughters for our father, we gave him.
I was blessed enough to be there to watch it unfold in front of me. Mold me and make me, help me to be
It was a beautiful story. Two sisters, and they were singing actually from different places. So one of them was in Brisbane and one of them was in Auckland, but really beautiful. And I think what really strikes me about their story is the importance of self-determination. And that's what I wanted to talk a little bit about. Linda Tuiwai-Smith, who's a Māori academic, has written an amazing book called Decolonizing Methodologies. And if you're a researcher interested in equity, I would really suggest that you read it. And she writes, our survival, our humanity, our worldview and language, our imagination and spirit, our very place in the world depends on our capacity to act for ourselves. And I think that's a message that translates across to all of us and is really important to bear in mind when working as an ally, which is what a lot of us aspire to do within the palliative care and equity space. But I think there's a real danger that in acting in that space, we can do more harm than good. And if you read some of the Black Lives Matters writings, there's some really interesting reflection within that. And this piece in the Black Mirror reflects that the most common characteristics of individuals and institutions that operate as white saviors is their failure to acknowledge that the communities they want to help have the power and knowledge to solve their own problems. So in terms of my reflections on where to start with promoting equity within palliative care, that would be absolutely the place to start with people's capacity for self-determination, to start with the strengths that they bring to a situation. And then finally, as I said at the beginning, we all have to commit to addressing equity, because actually achieving structural change within palliative care to the extent where equity is realized involves massive shifts and massive shifts in power, and it won't be easy. So it's something that we all have to center within our work. And again, it's interesting to look at some of the writing around white fragility to reflect on some of the challenges that we're likely to experience, and certainly that I've come across, and I'm sure many of you have come across. Often there's resistance, denial, and claims that we are doing this already. And I've heard that quite a lot within palliative care. We're already committed to doing this, but without really achieving the outcomes that would make that aspiration translate into reality. And again, as Robin D'Angelo argues in her book, White Fragility, each white person believes herself the exception, one of the very few souls magically exempt from a lifetime of racist conditioning. And again, this is why I'm arguing that we need to start with ourselves. We really need to start with critical self-reflection and then move to thinking about how to support self-determination. But moving towards a social justice position will involve difficult conversations because really, essentially, for equity to be achieved, it means that resources have to be moved around. And within palliative care, we already struggle for resources. So, you know, to understand that some people will lose out so others can gain can be a really difficult thing to talk about and to actually achieve in practice, as can genuine power sharing, because that can be scary, because you have to cede control of the outcome, because you have to genuinely enable people to be involved in making decisions. And that's certainly something that I found in my research, that it can be scary to let go, to let other people make these decisions. But ultimately, that's what you've got to do. And you get to places where you would never have got to before, because you're limited by your own imagination, by your own conditioning. I would also argue, and I think a few other brave souls have said this as well, that there's a special sort of palliative care fragility, where I think sort of the image of palliative care as a discipline that is out to help people and has this very special place within the public imagination, certainly in relation to hospice. It can make conversations around equity even more difficult. And certainly I've sort of presented data that we've gathered around equity issues, and I've been told very firmly by health professionals in the audience that that's not true, that, you know, I've cherry picked my participants. So I think that's something that we collectively need to work at, and that we need to challenge ourselves about all the time. So being an ally for many of us will be a really critical part of this move towards equity. And again, looking at some of the Black Lives Matter's work around what it truly means to be an ally can be really helpful. And these are some of the things that I've learned. You have to know when to stand up and when you have to use your power and privilege to say the difficult things, but you also really, really have to learn to shut up and to listen. And I think genuine listening, and I can say this certainly within the academic space, is really rare. And similarly within consultations, often, you know, we open up spaces to listen, but is that really genuine listening? So you need to recognize and use your privilege, as I said. You need to accept criticism. You need to accept criticism for your own actions, but you also need to acknowledge there's a lot of anger out there often around the experiences that people have had and that their sort of generations before them have had, and they can bring that anger into this situation where you feel like you're just trying to help, but that's why you just have to acknowledge that this is not about you. Don't put the burden of educating you onto others. I think that's really important. And I think, you know, there's lots of information out there, which means we are able to educate ourselves. And we're able to educate ourselves from the point of view of the communities we are trying to work with. And then ultimately, you just have to keep showing up and you have to keep learning. So I still feel like I'm, you know, near the beginning of a journey of learning what this truly means. And as I said right at the start, I think that's really true of palliative care as a discipline. And I'm just hoping that my experiences can help the discipline in some small way move forward in this hugely, hugely important area. So in conclusion, developing an equity agenda in palliative care, where should we start? We need to start with ourselves. We need to reflect before we act. We need to support self-determination and prioritise amplifying lived experience. And then finally, we need to work out how to be a good ally. And we have produced some resources that could potentially help, particularly if you're working in the education area. So we use a lot of creative arts methods, and we find these are really compatible with working with Māori as well as other structurally marginalised groups. And we've produced a series of resources, such as digital stories like the one I showed you. We've done 2 graphic novels, one around gender, and we're just finishing one around poverty and deprivation. And we've just got some funding to actually incorporate the gender novel into nursing education and to evaluate how students experience that. And again, if that's something you're interested in, there's potential to be involved in that. My colleague, Dr. Lisa Williams, who's a very talented author and writer, has written a play around lesbian, gay and bisexual experience of entry into aged residential care. And that's a radio play that I think is on our website. And then obviously there's the web resource that we produced, which you might feel, well, that's not very relevant because it's about Māori in New Zealand. But actually, I think if you look at it, you could see how that sort of format is really transferable to supporting other groups of people to think about how they would like to educate their own communities around palliative and end-of-life care. And as I said, here are the references to everything that I've talked about, and these will be available to you. And I'd just like to thank the organisers again for giving me space to talk to you today. I do recognise that that's a privilege. I'd always love to hear what's going on and how you're getting on with promoting equity. And best of luck with your discussions about finding a way to move forward with your important work.